This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Neurosurgical Review, published in 2026. It's a systematic review titled Deep Brain Stimulation for Clozapine-Resistant Schizophrenia, a systematic review of target-specific outcomes and stereotactic technical considerations.
This is a timely topic, Ilara. We often think of schizophrenia purely as a psychiatric domain, but as our understanding of circuit-based models evolves, it is increasingly being viewed through the lens of a disconnectivity syndrome. For our residents listening, that's a disintegration of mental processes driven by an imbalance of neurotransmitters.
Exactly. The paper highlights that while schizophrenia affects about 1% of the population, roughly 20 to 30% of those patients develop treatment-resistant schizophrenia, or TRS. The gold standard for TRS is clozapine, but the real challenge for us in neurosurgery comes with the subspecifier, clozapine-resistant schizophrenia, or CRS.
Right. The paper notes that up to 60% of patients either fail to respond to clozapine or simply can't tolerate it. When you reach that CRS stage, the prognosis is quite grim, higher relapse rates and a massive socioeconomic burden. This study looks at deep brain stimulation, or DBS, as a reversible modulation for these pathological circuits.
It's a small field currently. This systematic review identified only 6 clinical studies that met their inclusion criteria. They actually excluded a 2023 paper by Mansour, leaving a total study population of just 21 patients.
Small, but the technical details are where it gets interesting for our audience. Let's talk about the surgical rationale first. The authors describe a dual pathway model. Could you break down the targets they reviewed?
Of course. The targets were essentially divided based on the symptoms they aimed to treat. The nucleus accumbens, or NAC, was the most common target, used in 11 of the 21 patients. The rationale there is to modulate the reward circuit and dampen the hyperdopaminergic signals in the mesolimbic pathway that drive positive symptoms like hallucinations and delusions.
And for the negative symptoms, the loss of information flow or hypoactivity in the prefrontal cortex?
For those, the study looked at targets like the subgenual cingulate, or SCG, used in 4 patients, and the subgenual anterior cingulate cortex, or SGACC, used in 3. These targets aim to restore network integration and alleviate those negative symptoms like social withdrawal and lack of motivation. There were also smaller cohorts targeting the habenula, that was 2 patients, and 1 single case targeting the substantia nigra pars reticulata, or SNR.
From a stereotactic perspective, these aren't your bread and butter Parkinson's targets. The paper goes into some detail on the imaging and localization techniques used. What did the review find regarding the technical execution?
Precision is clearly the priority. Most studies utilize 3 Tesla MRI, using specific sequences like T1-weighted, T1 inversion recovery or T1-IR, and STIR to map the microstructural architecture. They also emphasize diffusion tensor imaging, or DTI, to guide leads towards specific white matter tracks.
And in terms of determining the actual coordinates?
They found 3 primary approaches: statistical atlas-based coordinates, direct MRI visualization, or a fusion of patient-specific imaging with stereotactic atlases. It's important to note that all cases in this review utilized conventional cylindrical leads and open-loop stimulation. We aren't quite at the closed-loop stage for schizophrenia yet.
Let's get to the results, which is what the residents are always asking about. How effective was this in these 21 patients?
The primary metric was the change in the positive and negative syndrome scale, or PANSANS total score. The outcomes were, well, they were highly variable. Reported PANSANS total score changes ranged from as low as 11% to as high as 85.7%.
That is a massive range. 11% is barely a clinical ripple, while 85% is life-changing.
It reflects substantial inter-individual variability and, as the authors point out, methodological limitations across the studies. However, the review did suggest a preliminary therapeutic signal, particularly with NAC targeting for those positive symptoms.
Now we have to talk about safety. These are complex patients. What did the review show regarding surgical complications?
Out of the 21 patients, surgical complications occurred in 3 cases. That's a 14.2% complication rate. The specific events were infection and hemorrhage. For a neurosurgeon, that's a reminder that while the brain targets are psychiatric, the risks remain very physical and standard to DBS.
14.2% is not insignificant in such a small cohort. It underscores the need for these procedures to be done in specialized neurosurgical research settings. One thing the paper emphasized towards the end was the need for better reporting in future trials.
Yes, the authors were quite specific about that. They argued that future investigations should prioritize standardized stereotactic reporting and volumetric lead reconstruction. We need to know exactly where these electrodes are sitting relative to the patient's specific anatomy to understand why one patient has an 85% improvement and another has 11%.
It's the black box of neuromodulation. If we don't have the volumetric data, we're just guessing at the circuit modulation.
Exactly. They also mentioned the absence of controlled trials. Right now, we are looking at small, open-label cohorts. To really move the needle for clozapine-resistant schizophrenia, we need long-term safety assessments and more robust, standardized data.
So, to summarize for our listeners, DBS for CRS is an emerging field targeting dysfunctional corticostriato-limbic circuitry. The nucleus accumbens is the primary target for positive symptoms, while subgenual regions are targeted for negative symptoms. While there's a therapeutic signal, the technical heterogeneity is still a major constraint.
Right. And for the residents, remember the imaging requirements. 3 Tesla MRI with T1IR and DTI are becoming the standard for these more niche psychiatric targets.
Well, that's a deep dive into a very specialized area of functional neurosurgery. Thank you for walking us through that, Dr. Alara.
My pleasure, Dr. Aris.
And thank you all for listening to the Neurosurgery Hub podcast. Stay tuned for our next episode where we continue to bridge the gap between clinical research and surgical practice.